Good morning. It is 9 o'clock, so we'll go ahead and get started here. I'm Christy Gagne. I'm a program manager for Telehealth Rocks. Telehealth Rocks is a federally funded program that focuses on school-based behavioral health, and we do this by working on social determinants, supporting school-based services, and telementoring training just like this one. We've got Telehealth Rocks team members, Evelyn Nelson, Robert Stiles, and Julie Frajat here to help, and they may be putting items in the chat or responding to questions or chiming in during the session. So feel free to reach out to any of us if you need anything. We're glad you're here for this webinar to discuss early childhood research on parent-child interactions, and we've got just a few notes for you if we can go to the next slide. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted and you can use the chat or unmute to ask questions. And then it's very helpful to either type your first and last name in the chat so we can track attendance, or just make sure it's visible on your Zoom screen. Next slide, please. We have no disclosures, and everything presented today is evidence-based and currently accepted within the profession. Next slide, please. And then after the session, just a few notes. We will share the slides and recording with you just as soon as we can. All links that are on these slides will also be sent in the follow-up email. Just give us a little bit of time to process everything. And then we do appreciate your feedback on our follow-up survey. We really do look at all of those and use them to help plan future training. So we love hearing from you and getting your feedback on our very short surveys. We will send a certificate of attendance afterwards. Again, it takes us just a little time to process them, but we'll send those via email to all of you when they're ready to go. And then if you have any follow-up questions, you can send them to our Telehealth Rocks email listed there on the slide. All right, next slide, please. And we're thrilled to have 3 experts from the University of Kansas Medical Center here today to share their early childhood research on parent-child interactions. You'll hear from each of them, and then we'll do questions at the end. So I'll hand it off to them to introduce themselves.
All right, thank you, Christy. Hi, everyone. My name is Sarah Behrens. I am a postdoctoral research fellow in the Department of Pediatrics here at KU Medical Center. I am a social worker by training. Worked in the school education system for about 10 years with the TASN network, and have transitioned to research specifically on early childhood and parent-child relationships. And I'm excited to be here with you today. Brenda, I'll hand it off to you.
Good morning, everyone. I'm Brenda Salley. I'm a clinical psychologist, also in our Department of Pediatrics at the University of Kansas Medical Center. I have 2 hats that I wear. One is in clinics where I work with an interdisciplinary team, and we do early childhood evaluations for children 3 and under when there's a concern about development. And the other hat that I wear is what I'm here to talk with you all about today, which is the research side. And I focus on early social, emotional, and language development in young children, and really thinking about preventative ways to support children and families. Anna, I'll let you go.
Hi, everyone. I'm Anna Wallisch, and I am an occupational therapist and an assistant professor also in the Department of Pediatrics at KU Medical Center. I spend part of my time as the occupational therapist in our interdisciplinary feeding team at KU Medical Center. And then I spend my other time on research projects focusing on early intervention and access to early intervention services for children with neurodevelopmental conditions, as well as supporting families who have a child with challenging eating behaviors.
Thank you. I'm going to get us started to frame today's conversation. We're going to be focusing in on the research around parent-child relationships. As some of you may know, they are really that foundational aspect of early childhood development, from social emotional growth to language, learning, and even long-term health outcomes. So today, each of us are going to be presenting a part of the larger effort to support these relationships, from research that deepens our understanding of early interactions to developing meaningful interventions to make sure those strategies reach real-world settings through implementation and dissemination. Here at KU Medical Centers, we're proud to be part of this continuum. Our commitment to early childhood research spans disciplines, including pediatrics, developmental science, social work, education, and many, many more, and prioritize collaborative work with families and also community partners. No matter what angle you enter from, the relationship between young children and caregivers is really at the core, and that's what really grounds and connects all of this work. So we're excited to share some of the research we've been a part of, and that's also just getting started. So I'll go ahead and jump in with some of the work that I'm exploring around social emotional development. It's really how young children learn to express those emotions from relationships and navigate the world around them. It's that foundation to those big feelings, trusting people, and really feeling safe to explore and learn. What we know from the research is that social emotional development grows through the kinds of nurturing, responsive interactions we talk about in early relational health. And those are those everyday moments between caregivers and children that just really builds those strong bonds. So when we support social emotional development, we are really helping to strengthen that early relational health. And when we strengthen early relational health, those parent-child relationships, we are giving social emotional development the best chance to grow. So another way of thinking about that is promoting social emotional development is really one of the more powerful ways we can support those early health relationships and healthy kids, starting from birth, and doing it in the places where families already go. So that's really important to our work, is thinking about where our families are at. To give you a little bit more context on social emotional development, this definition from 0 to 3 is one that we use in the literature the most. We think about that growing ability to really form close relationships, manage and express emotions, as well as explore and learn. And that's all, again, within that context of their family, community, and culture. So it's not just one thing, it's really social emotional development. It's that whole set of skills that really grow through everyday interactions, really grounded in that foundational relationships that those kids have. And then it's shaped by the culture in which our kids and families are being raised. So a little bit about the project that I'm starting to work on. This is the pyramid model. Some of you may be familiar with this model framework. It's been in the early childhood education field for many years, lots of research around it on promoting social emotional development to really reduce challenging behaviors through positive relationship-based strategies. As you can see, it's built on 3 tiers. Universal supports for all children, followed by targeted strategies for those who just need a little extra help, and then really that intensive individualized intervention at the top of that pyramid model. What's most important here is how this model shifted the field. So with the pyramid model in education, we've moved away from reactive discipline and really moved towards proactive, developmentally informed practices, really grounded in connection to build those relationships, and also co-regulation. So we see a clear alignment between this framework and the goals of early relational health, especially in those bottom 2 tiers, universally, and then for those kids who just need a little bit of support, where those nurturing caregiver-child relationships are the focus. We have decades of research that shows us that these supports reduce suspension and expulsion in preschool, improve emotional regulation, and strengthen caregiver-child relationships. But as I mentioned, most of this work has been done in the classroom setting. So I'm working on a proposal to adapt some of these evidence-based practices for primary care. So in the pediatric primary care settings, and really thinking about creating a public health ecosystem of early relational health and interventions. We plan to equip pediatric providers with tools and information to support families in building these skills early and to recognize when additional help may be needed. Families already look to healthcare providers for guidance, especially in those first 5 years, and so we want to meet them there with those tools that really work. So here's the heart of our proposed project. We're taking the proven strategies from the pyramid model in early education and then bringing them into that pediatric primary care setting. We really want to train providers, and that includes a whole clinic, including your doctors, nurses, any support staff, to do 3 big things during those everyday well-child visits. Promote social emotional development with all families, prevent concerns by strengthening relationships early, and partner with families through open, strengths-based communication. So just like what we've done in the classroom, the key is really to being proactive, relational, and developmentally grounded. This diagram kind of shows the vision that families, providers, and communities are working together, all within that early relational health framework. By aligning these pyramid-informed strategies with existing pediatric workflows, we really believe we can make a meaningful impact, especially for families facing barriers to access or support. So to give a preview of what we're thinking about in terms of the intervention, we want to ensure families and providers have simple, practical tools that they can use every day. So we are thinking about developing a community toolkit that will include things like flyers, posters, cards that can be shared with families up on the walls for people to see that have that clear language and visual cues. Think about like a clinic lobby or a library, even the grocery store. These are co-designed with families to ensure they feel relevant, respectful, and also easy to understand. The second piece that we'd like to develop is a texting campaign, a low-cost, high-reach way to share short strategies with families right on their phones. The idea is to really provide regular, developmentally grounded tips like how to name and validate emotions or how to set up soothing routines. We can also include prompts for parents to talk with their providers when it's time for that next appointment, creating more opportunities for the real partnership during well visits. We're hoping that together these tools can help move social emotional development and early relational health from something we talk about occasionally to something families really live, see, and feel supported in every day. So here are some, I've got some key resources, but before that, some ways for you guys that are on the call today to think about being involved. I think a big piece is really starting that conversation. So using feeling languages in everyday work that you do with families and young children to support that social emotional development. Be a thought. We'd love feedback from our partners. So if you're interested in this and want to be a thought partner, we'd love to connect with you. Staying connected, I have some resources for you to do that. So you're in the know of kind of what's going on. And then sharing your voice, what would support you in promoting social emotional development in your setting. So thinking about the context in which you work, how can you bring this information to your colleagues, families, and the young children that you support? I'm going to wrap up with a few resources, and I know Christy has shared with us that these will be sent to you afterwards. So I encourage you to check out the pyramid model resources on challengingbehavior.org. They have a wealth of information and resources around social emotional development. Right now, it's more education-based, but it's all applicable and usable for anyone working with young children. The second resource is the CDC's Milestone Tracker app. This is a great resource for families with young children who want to monitor their child's development. It's a really good tool for engaging providers when you go in for those well-child visits by completing the questionnaire before, for example, like the 15-month visit. You can share that information with the provider and really build their knowledge base of where your child is developmentally. And then the third one, the Center on Developing Child at Harvard, they always have the latest research around development and how we can best support those early relationships. This time, I'm going to pass it on to Dr. Brenda Salley.
Thanks, Sarah. So what I wanted to share with you all is another aspect of that early parent-child relationship, thinking about the early language interactions that children have. And I will go to our next slide, Sarah. So when we think about those early language-rich interactions that children have with their caregivers, we're thinking about those early back and forth conversations even before a child has words. So this is when a parent is talking to a child or a caregiver or a teacher. The baby's smiling and the caregiver keeps that conversation going. We have many decades of research that show us that the quality of those early interactions from birth on are really critical for child development. Those interactions are shaping brain development, those early neural connections in all areas of the brain, but particularly in those language development centers. And that early neural activity is very important for setting up school readiness and many outcomes that we care about for young children. So much of this work actually started here in Kansas, where we followed children and families, and we were able to see that those children who had more of those higher quality language interactions started school better prepared with larger vocabularies. They did better in school, were more likely to graduate from high school. And actually we can link those early experiences all the way to long-term health outcomes, living healthier lives. So this is really a place where we can think about preventative intervention for children and families. And there's a lot of interest in how we can support this particular kind of interaction. This is something that the American Academy of Pediatrics really identifies as an important thing to focus on in early development. And there's even a focus from a public health perspective in terms of thinking about how do we really reach families with this information about supporting early development. Even though we know a lot about how to promote these kind of language-rich interactions for young children, the barrier has been getting this information to children and families and into the places where children are. So the approach that we have been taking is to address that as a barrier. Next slide, please. So one of the places that has almost universal access to children and families is primary care. As Dr. Behrens was saying, well child care reaches almost all children and families, even in our most rural and underserved areas during those first 3 years of life. And so when we think about a place to embed evidence-based approaches to support child development, this is really a nice opportunity to leverage those regular visits that children have with their pediatricians. So we have been, over the last 4 or 5 years, really taking a public health initiative called Talk With Me Baby and developing it as a resource that can be used by pediatricians, nurse practitioners, and the whole healthcare team in well child visits. Next slide. So we have been developing and piloting this, and this year we are starting a large trial that will be taking place here in Kansas City and actually in Atlanta, Georgia, where we're working with community clinics to compare clinics who get that Talk With Me Baby training to Care As Usual. And the reason that's important is because we want to be able to show that this makes an impact in terms of really changing parents' behaviors and also improving child language outcomes. If we're able to show those effects, then we can continue to build and scale this and really advocate for this as an approach in well child care. So we will be enrolling about 400 children and families into this trial, and we will be following them to look at a variety of outcomes, but I'll just share one with you today. Next slide. So we'll be enrolling babies at 1 month of age and following them until they're 2 years old. We'll look at a variety of parent outcomes in terms of their knowledge about early language promotion and child language outcomes in terms of the vocabulary development. But we'll also be able to look at the quality of those early language interactions using something called LENA, which you can kind of see in the left panel here. It's a little device that goes into a vest that a child wears for a day at a time. And it gives us input about those conversational back and forth turns that children and families have. So it's a really powerful way of looking at when we share information about language promotion in well visits, are we really changing and optimizing those early language interactions? Next slide. A little bit about what the Talk With Me Baby approach is itself. It's built on the idea of language nutrition. So just like a child needs healthy food to grow, they also need those language-rich interactions to have healthy brain development and healthy school readiness and success in school. And the important thing is that language nutrition is free and it can happen in all the everyday activities that children and their caregivers have. Next slide. We are working with our healthcare clinics and partners to empower them as Talk With Me Baby coaches. But these are things that apply for all of us when we're interacting with young children and their parents. We want our healthcare team to educate families to share the importance of those early language interactions, the importance of early language nutrition. We want our healthcare partners to really model how to have those language-rich conversations with children. And we want our healthcare team to provide some brief coaching to really transfer capacity to parents and caregivers to use those same strategies with their children. And then the last piece of the approach is having families receive a language nutrition prescription. So specific, concrete way that they will take the strategy that their pediatrician talked with them about and really use it in their everyday with their child. So this model is built on a healthcare model of that transferring capacity of the pediatrician as modeling and educating to empowering the family to use those same skills. And the idea is that over repeated well-child visits, families are increasing their capacity for those language-rich interactions with their child. Next slide, please. One of the kind of key ingredients of this approach is really focusing on some specific strategies. So for those of you who have taken your child to a well-child visit, you know that your pediatrician probably talked about the importance of language development, but they may not have specifically talked about how you can support language development. So this approach is meant to bridge that gap. And one of the strategies that we focus on is a strategy of taking turns. So encouraging the caregiver to notice what a child is looking at, what they're paying attention to, comment about it, label what they're looking at, give the child a turn to respond by smiling, looking at the parent, or talking when they're older, and then keep that conversation going. Sometimes we think about this as those serve and return interactions, but we're thinking about the strategy of keeping those conversational turns going. We know that the more back and forth interactions we can encourage, the better for those early language development. Next slide, please. And then another strategy that I'll highlight and that would be something that you can use as you're interacting with children and families also is the strategy of narrate your day. So this is the idea of talking about what's happening around you, what's happening around the child, what the child is doing, what you're doing together, and really describing using that language, those rich language descriptors to give that good rich language input to children. And this can happen anytime when a family is walking down the street, when you're in the grocery store, as well as those interactions that we think about, like reading together or singing together. Next slide, please. So I'll just leave you with a few resources. Talk, Read, and Sing Every Day is a nice kind of handout style resource for caregivers and for professionals. There's a variety of resources on the 0 to 3 webpage, and a lot of really great resources on the Cox campus. A lot of these are video-based and really built for the educational system, and terrific resources that I encourage you to check out as well. Okay, I'll hand over to Dr. Wallisch.
All right. So we'll switch gears a little bit, and I will talk a little bit about parent-child interactions and relationships in the context of mealtime. And so the focus of much of the research that I'll talk about is with autistic children, but the importance of responsive interactions during mealtime is relevant to all children. Mealtimes are often a really special time for parents and children to check in with each other and connect. And even at birth, feeding accounts for a large portion of how infants and parents are interacting. Next slide. So just a little bit of background on why mealtimes and eating are important to focus on in autism. Challenging eating behaviors in autism are highly prevalent. Depending upon the article, it could be up to 83% of children with autism have some of these challenging eating behaviors. There's also a greater risk for obesity in autistic children, and there is an overlap between anorexia nervosa and autism as well. So I think some studies suggest that like about 22 to 26% of those with anorexia also have an autism diagnosis. And many of these challenging eating behaviors persist into adulthood. And it's difficult to think about different treatment options because we know that there are many factors that are likely underlying these. But today we will focus on just kind of one of the potential factors, and that's the importance of the parent-child mealtime interactions. Next slide, please. So I wanted to start off by talking from the parent's point of view with mealtimes and when thinking about these challenging behaviors. And so this was one family that we worked with, and she said to us, "We are concerned he is too skinny, like we're worried about his health. I mean, every day I open the fridge and I'm thinking, what am I going to feed this kid today? That is the hardest part. It's stressful on top of everything else." And it's well known in the literature that these challenging eating behaviors are highly stressful for parents. And I think it's especially so because eating is a basic need. And as parents, we want to meet our child's basic needs. So I really want to make sure that we better support parents during these meal times. Next slide, please. And so to support parents during these meal times, we know that parent-child interactions are a key component of responsive feeding interactions during meal times, which can be helpful for increasing a child's food acceptance. Next slide, please. So related to in autism and feeding, we know that mealtime is super stressful for families. We also know that parents often make numerous mealtime accommodations for their child or make food choices to prevent triggering a challenging behavior within their child. But within other research related to pediatric weight-related conditions, we also know that when parents are stressed about the child's weight status, parents sometimes use more forceful or coercive types of prompts. And this is extremely well-intentioned, but it is often counterproductive. And I mean, I will admit I have been guilty of this as well with when my child got sick. I really wanted them to just take another bite. So I think we're all this happens to everyone, but it is often counterproductive to what our goal is to get them to take just one more bite. But interestingly, their research has shown that when children show greater food acceptance, parents in turn show more responsive parenting. And when parents show more responsive parenting strategies, then children show more food acceptance. And so there's this bi-directional interaction between the parent and child and back and forth during meal times. And that's what I'm really interested in. Next slide, please. And so one way to quantify some of these bidirectional interactions is through this really big word, interpersonal physiological synchrony, or some are calling it physiological linkage now. But it's really this dynamic co-regulation of these really micro level behaviors in physiology between the parent and the child. So if a parent's physiology is going up we often see the child's physiology going up as well, and that's considered a synchronous moment. I also like to think of it as times in which, like, we say, like, oh, we were so in sync, or we were on the same page. It's kind of some of those moments. But it's a process that I believe it starts in utero, and it's known to positively influence child self-regulation and cognitive development. Strong parent-child relationships and parental sensitivity are linked to greater physiological synchrony and can actually act as a modulator to a child's response to stress. But if synchrony is low, it can also spread parent stress to the child. And so in instances of parent anxiety and stress, which is very common in mealtime, sometimes parents tend to use strategies that begin to override the child's cues. But there are some really interesting examples of synchrony, even in other literature. So there are studies suggesting that in couples, when there's greater synchrony, there are higher ratings of marital satisfaction. There's also studies with an orchestra and a conductor, and when they're at rest, they're asynchronous, but as soon as they're playing together, their physiology is actually in sync. So it's kind of this really interesting phenomenon. Next slide, please. So when thinking about the literature on synchrony and feeding, there was a study in preterm infants, and what they found was that when there was more mealtime behavioral conflict between the parent and child, or more asynchrony, this was associated with maternal concern about the child's medical vulnerability. So kind of that stress and anxiety related to the child's health and well-being. As well as in early infancy, behavioral synchrony was in turn related to a child's willingness to eat. Next slide, please. So within synchrony and autism, it's mixed right now, and there's not a ton, but some research suggests that children with autism may show less synchrony with their parents. And emerging research also suggests that parents may use more compensatory strategies during their interactions with their child. And so our study and what we're really wanting to do is to begin dynamically quantifying these interactions with physiological data to better kind of understand some of these individual nuances of these eating behaviors. Next slide, please. So this is really, really preliminary data, but I thought I would at least show you something and kind of what the data looks like and what the process that we're going through looks like. So this is only like a small subset of the full data set, but I'm hoping this will kind of help you see what's to come. But this data is on 10-minute video observations of mealtime. And so parents provided the child with a preferred food, and then after about 5 minutes, they presented a non-preferred food. We recorded these all with GoPro cameras. One parent and one child wore our sensors, and we captured electrodermal activity. Our sensors just are kind of like an Apple Watch that measures this. Next slide, please. So the subsample that I'll show you today is 8 autistic children. They were all 3 to 9 years of age. There were 4 in the autistic group and then 4 in the non-autistic group. We recruited picky eaters for the autistic group and non-picky eaters for the non-autistic group. This was not a diverse sample, but hopefully our full sample will be more diverse. Next slide, please. So these are just average correlations or trying to show the relationship between the parent's physiological data and the child's physiological data over the 10-minute observation. And within the autism group, on average, they're showing no relationship between their physiology during the mealtime. And in the non-autistic group, there's like a weak positive relationship across the 10-minute observations. But I will say this is across the whole 10 minutes, and there's a lot that can happen and a lot of ups and downs that can happen within that 10 minutes. So that's kind of our next step with looking at the data. Next slide, please. So this is our next step with kind of visually examining that whole 10-minute observation. And what we see here is kind of in one, there's just a lot of variability, and there's kind of a low correlation or no relationship between their physiology. But in the third parent-child dyad, it's a pretty positive correlation. They're pretty in sync with their physiology. And then in the fourth one, they kind of start off in sync, but then we see that the parent is in blue and the child is in red. And we see that the child is going down, but the parent's physiology is going up. So they become a little bit more asynchronous. And then why you visually inspect your data too is if we look at number 2, the child's physiology looks really low. And when I went back to the video, the child is taking on and off the watch a lot. So that's probably what's happening there. So that's why we always look and visually inspect the data. Next slide, please. So this is the next step, which these are called wavelet coherence plots, and these are really confusing. And I am honestly learning these as well. But what you need to know is the outline portion are portions where we see significant synchrony. And what these plots tell us is the magnitude of that synchrony, which is kind of the dark red portions. They also tell us the direction of synchrony, whether it was they were in sync or they were asynchronous. And it also tells us if the child or the parent was leading that synchronous or asynchronous moment. So we'll specifically look at one of these on the next slide. So when we look at this, this is that outlined area of a significant synchronous moment. Since the arrows are pointing right, it means that it's a positive synchronous moment. Up and to the right means that it's child-led, and then it just kind of goes flat, so it's neutral. And then when it goes to the right and down, it means it's parent-led. And when I go back to the video on this one, what's happening is the parent and child they're eating and they're just talking about their day. And this is often a strategy that we tell parents is to not talk about the food and just make it a really positive interaction during the mealtime. Next slide, please. So this is an example of a significant asynchronous moment. The arrow is pointing to the left, and when it's up and to the left, it means that it's mostly adult-led. And when I go back to the video here, we see that it's interesting. The mom's physiology is actually her arousal is increasing, and the child's is staying pretty steady. And she's getting ready to prompt her child to take another bite. So thinking about how that just preparing for the stress of trying to get your child to just take one more bite of food. And so overall, I think this is an interesting way to begin understanding some of those nuances to these parent-child interactions, and perhaps a better way to begin developing personalized interventions by looking at these individual plots, individual parent-child interactions, and seeing which strategies are supporting synchrony that are in turn supporting the child's food acceptance as well. Many of the interventions that we do are parent-mediated interventions and parent-led interventions. And so this may also be a way for us to easily kind of understand their treatment response or how their relationship or their interaction with their child is changing across the course of an intervention. Next slide, please. I just, of course, want to always acknowledge my mentorship team, statistician, the funding that supported this work, and of course, all of the families and children who trusted to tell me about their child's eating and trusted me to try to help them find a better answer. Next slide. Of course, lots of references. I will say too, and I think this is on the resources sheet as well, Feeding Matters is a wonderful group and organization that has great resources for feeding for caregivers, but they also have a lot of training opportunities and webinars for clinicians as well. Next slide, please. All right, so I think that this is time for any questions.
Mm-hmm. And we do have a question in the chat. This is for you, Dr. Wallisch. They wanted to know a little bit more about the physiology and what was being measured. They mentioned blood pressure, heart rate.
Yeah, that's a great question. So we are specifically looking at electrodermal activity or skin conductance. It's really like our sweat glands is what it is. But you can look at it with heart rate variability. The reason we chose electrodermal activity is because we also have a condition where children are playing, and heart rate variability is a little more susceptible to movement. And we know kids, they enjoy moving when they're playing. So that's kind of why we chose the electrodermal activity. But yes, you can use it with heart rate variability as well. It's a great question.
And then we do have another question that came in. What range is considered for positive synchrony?
That's a really good question. We base it on those plots. And what we do too is that's kind of something of our next step is getting the actual numbers from those plots. So we look at that magnitude and it's individual for each child. So there's no like exact threshold. It's kind of how just that individual parent-child dyad is changing. And it's in those kind of on those plots, that like outlined area. So we look for more so those like significant areas of synchrony. But that's a really good question. And it is confusing. And we have to kind of try to pull out the numbers from those plots as a next step, if that makes any sense. Oh, thank you, Christina.
Right, and I'm not seeing any other questions. Feel free to type them in or unmute to ask, and we can make sure that we address them. I think we can go ahead and hop to the key takeaways if we'd like to. Oh, we did have one other question come in.
Yep.
Just one second. What criteria, this is for Dr. Behrens, what criteria is used to select a child to participate in the study?
Oh, this might be for Brenda. Are you referring to Talk With Me Baby or the social emotional?
She said it was a question for you.
Yeah,
Not
right
sure.
now at this time, we're in the development phases, so we don't have a specific study. We are going to be kind of targeting birth to 3 though for the social emotional in the pediatric primary care settings.
Sounds great. Dr. Salley, do you want to let us know how you select participants for your study as well?
Sure. So we have participating clinics who are interested in being involved in the study. And then within those clinics, all the children in a participating clinic can be part of the study if they would choose, if they would like to enroll. Whether or not they're in the study, for us to follow them and look at their language, child language and parent outcomes for the clinics who are in that Talk With Me Baby arm where they're trained to do the intervention. All of the children and families in the clinic would be receiving the intervention. We're just enrolling a subset of families in each of those clinics to follow them and look at their outcomes.
Thank you.
We can let more questions come in if you guys think of any, but we want to kind of wrap up with kind of our key takeaways from each of our presentations. You know, for the social emotional, by applying that public health approach, we can really bridge that work from education to healthcare. It's kind of a goal for us, supporting children's social emotional development and really strengthening family relationships from the earliest years, from the start at birth. And for Dr. Brenda Salley's, it's adding that universal language promotion into those routine well childcare visits. It's really a powerful way for enhancing the early language, childhood language development, school readiness, and optimizing long-term health based on the research that we have. And then from Dr. Wallish's, responsive parent-child interactions during mealtime are really important for supporting child dietary intake and that physiological synchrony, which might be a novel way for us to measure nuances to these interactions. So we can start to perhaps look at it across different routines, not just mealtime. Christy, I'll hand it back to you to close us out.
Sounds great. Thank you. We wanted to know in the chat, what's one thing that you'll take away from this session? Some examples are, did you hear a new piece of information? Or is there anything that you're going to share with a parent or coworker? And you can just type in the chat and let us know what your key takeaways are as the audience. And then we'll share speaker contact information out with you. It'll be on the slides. So if you have any questions or want to follow up, emails will be on there. And we want to say thank you so much to our wonderful presenters for sharing their research and finding out about, their findings about parent-child interactions. So thank you for the wonderful presentation today. And we've got thank you to everybody putting some takeaways here in the chat. And then just to wrap up, we want to thank everybody for joining us today. We really enjoyed learning with you. And just a few follow-up items. There will be a survey in your inbox about the training, and it'll only take a few minutes to fill out. I believe there's 10 questions, and we really do appreciate your responses and use them for planning future trainings. We will send your certificates and follow-up emails or follow-up materials to your email. So watch for those in the next day or so. Thanks everybody for joining us, and we hope you have a great rest of your day.